Iniciamos.
Buenos días a todas y todos. Es un gusto estar con ustedes en esta quinta sesión del Seminario Web Salud Mental, Evaluación e Intervenciones Emergentes. Para nosotros es un gusto tener con nosotros al doctor Cuijpers, que es un experto en muchas áreas de la psicología, ha hecho investigaciones en intervenciones basadas en la evidencia desde hace varios años, pero en particular en las intervenciones digitales. Y es evidente que en el marco del contexto de la pandemia que estamos al día de hoy viviendo, es muy importante el conocer pues lo que el doctor ha investigado en los últimos años sobre este tema tan interesante para todos, y espero que sea de mucha utilidad para toda la audiencia. Bueno, pues sin más, vamos a comenzar. Dr. Pim, thank you very much to be with us. It's a pleasure to join us in this webinar, and we are excited to listen your conference because I think it's a very interesting topic because the COVID-19 pandemic, and we think it's a very interesting topic for Mexican psychologists. So thank you again to be with us on behalf of National Autonomous University of Mexico and the Faculty of Higher Studies Iztacala. Thank you. And if you want to begin, Pablo, go ahead.
Sure. Yes, we are really happy to have you here, Dr. Kuijpers. Thank you for accepting our invitation. For those of you who, for whatever reason, don't know who Dr. Kuijpers is, he's professor of clinical psychology at the Universiteit in Amsterdam, the Netherlands. He's also director of the WHO Collaborating Center for Research and Dissemination of Psychological Interventions in Amsterdam. He is specialized in conducting randomized controlled trials and meta-analysis of prevention and psychological treatments of common mental disorders across the lifespan. Much of his work is aimed at the prevention of mental disorders, psychological treatments of depression and anxiety disorders, and internet-delivered treatments. He has also published on several other research topics, including global mental health, student mental health, and psycho-oncology. Dr. Kuijpers has published more than 1,000 peer-reviewed papers, chapters, reports, and professional publications, including almost 800 papers in international peer-reviewed scientific journals. He's on the Thomson Reuters website list of the highly cited researchers in the first edition of the list in 2014. Well, thank you, Dr. Kuijpers, again for accepting our invitation. He will be sharing a lecture today named Digital Interventions in Mental Health. So again, Dr. Kuijpers, we are excited to have you here. And thank you again, really. This is an honor. So,
thank you very much for the kind introduction. And it's my pleasure to give this presentation today because I do think it's a very important subject. And I will try to not talk for more than 1 hour because I know how tiring it is to listen to somebody online. But I think I can give my main messages in less than an hour. And what I will do is I will first try to share my screen and hope that it works. Okay, here we should go. So I hope you can now all see my screen. And if not, please let me know because it's very difficult to talk and not see you in person. It would have been much more fun if this would have been in person, but that's unfortunately not possible. Can you see the first slide now?
Yes, we can.
Perfect. Okay, then I'll go to my presentation. And I will mostly talk about depression because depression is, well, it's obviously an important mental health problem, but it's also the disorder, the mental disorder that has been examined most compared to any other mental disorder. So there is a lot of research on depression. That's not automatically true that things that we find for depression are also true for other mental disorders. But I do think it's a good lesson for how can we examine how you treat mental disorders? And what I will do in my presentation is the following. I will first talk about a general thing about treatments of depression, a general problem we see when you try to treat people with depression. Then I will switch to a more broader subject and talk about psychological treatments in general. And we have done a lot of meta-analysis, and I will tell you more about that, which of randomized trials that have examined what works and for whom it works. And so we have done a lot of studies on that. And after that, I will focus on one specific type of psychological treatments, namely internet-based treatments of depression. And I will show you that it really doesn't matter how you apply psychological treatments for depression. You can do that individually, you can do that in groups, by telephone, or you can do it through digital interventions. And the evidence is pretty clear about that, and I will tell you more about that. But the next subject is that I want to talk about how can we apply the knowledge that internet interventions are effective. And we know from randomized trials that these interventions are effective, but we still have to examine in all these fields and possible applications whether it works in this situation for this population. And I will talk more about that in this subject. And then I will give a few examples of projects in which I was involved, and that can give you a good idea of what we know from research on digital interventions for depression. And in addition to that, I will show you a few projects that succeeded, but it's not true that everything works in digital interventions. And I will also show some results of projects that simply failed, because it's not, it sounds good and you have all these digital things and it sounds new and innovative, etc. But it also often fails, and there's no guarantee that if you apply one type of digital intervention, that it will certainly work in that situation. Well, and then I will end with a brief view on the future, where what can we expect in the coming year, decades on digital interventions, because the field is changing very rapidly because of the mobile revolution. Okay, the first subject, how to improve treatments of depression. If you want to know more about this issue, I wrote an editorial viewpoint paper about this in JAMA, and not everybody was happy with this viewpoint. Because what I said is that if you look at treatments for depression, a lot of people also get better without treatment. We call that spontaneous recovery, which is not the best term, so to say, but it does indicate that a lot of people get better even if they don't get treatment. And we know that if people get a pill placebo, that 38% respond. I will come back to that later. We do know a little more about these conditions now. So on the one hand, we have a lot of people who get treatment, but also would have also gotten better without treatment. And then at the other side of the spectrum, you have a lot of people who don't respond to anything. So you have to treat them once, twice, 3 times. And then after many treatments, they still don't get better. And what our treatments for depression actually do is that we focus on the group within. So that's where treatments have their benefits. The group who don't automatically or spontaneously recover, but they do respond and do not belong to the group of people who don't respond to anything. And so that also limits the capacity of treatments to make people better. And if you look at it from this perspective, the effects of any treatment, whether that's psychotherapy or pharmacotherapy, is really very modest. I don't go today, because we're talking about digital interventions, I won't go into the question whether antidepressants or psychotherapy is more effective or combined treatments. That's something we have done a lot of research on that too, but unfortunately I don't have the time to talk about everything before you fall asleep because I'm talking too boring stuff. Okay, the second thing. So the first thing was that you should keep in mind that our treatments are actually, they're effective, they're evidence-based, but the effects are modest, and it doesn't mean that it works in everybody. And I will go a bit more briefly, I will go more into that in a little more detail. So what we did in my group is that we do a lot of meta-analysis. And what we do is we search the literature every year for randomized trials examining the effects of psychotherapies for depression. And if you want to know more about that, you should go to this website. You can find much of the information there. And what we have opened up the most important parts of our data sets where you can compare psychotherapies with control conditions. And if you go to this website, you can make your own selections and you can run meta-analysis online without any additional software. It's all included in the Shiny app of this website. So if you want to know whether CBT works in older adults, if group therapy works in perinatal depression, if psychotherapy works in East Asia, just go to this website, select the studies, and run a meta-analysis, and you get the exact answers yourself. We're extending this now to other data sets on psychotherapy for depression, but we're also extending it to other disorders like borderline disorder, panic, social anxiety, but also psychotic disorders, insomnia. And we're trying to extend this. This is now, it's just a site to show what the possibilities are. But in 1 or 2 years, I hope we can have a much broader overview of all the research on psychotherapies. So, but that's where we come from. So this is what we do. I've been working on this for 15 years now, that we update every year the searches for randomized trials for psychotherapy for depression. And we now have more than 800 randomized controlled trials. And they examine all kinds of things. They compare psychotherapies with control groups, all these different types of psychotherapies. They look at trials comparing these therapies directly with each other so that you can see whether the effects of one is better than the effects of another one. They look at comparisons between psychotherapy and pharmacotherapy with combined treatments. They look at inpatients. They compare individual therapy with group therapy or digital interventions with face-to-face therapy. And so we have this whole body of research where we know so much about what works for psychotherapies for depression. And I wanna now go briefly through a few things we found there before I focus on the digital interventions. So these are the effects of psychotherapies compared to control groups. And these are the types of therapies that have been examined in at least 10 randomized trials. And what you can see here is that by far most studies have focused on CBT, cognitive behavioral therapy. But there's also quite a lot of research on behavioral activation, interpersonal psychotherapy, problem-solving therapy, but also completely different types of therapy, like non-directive supportive counseling, psychodynamic therapies, life review therapy for older adults. I assume that you know a little about these types of therapy. If you have questions about that, or you don't know that, maybe we can go into that at the end of my presentation. And what you see here are the effect sizes. And effect sizes, we indicate that with D, Cohen's D. We also often use Hedges G, but they're all standardized mean difference. And I call that an effect size. It's not completely correct, but otherwise I have to say all the time standardized mean difference, and that's such a long term. So I say effect size, and the effect size indicates the difference between the treatment and the control group after treatment in terms of standard deviations. So what you see here is, if you look at CBT, then you have 229 trials, and the difference between CBT and a control group who did not get the treatments is 0.82 standard deviation, which is, for researchers, that's easy to understand, because that's how you express differences between two groups with a normal distribution. But of course, it's very difficult to understand what it actually means, because the patients and clinicians just want to know, okay, what's the chance of getting better if I got that treatment? And I will show you later on some data on that. But what one way to express more in a more easy to understand or clinically relevant way is to talk about numbers needed to be treated. And I gave them here too. Numbers needed to be treated indicates the number of people you have to treat in order to have one more positive outcome than no treatment. And as you can see here, that's 3 for CBT. So you have to treat 3 people in order to make one person better. And what you see here is that the effects of all these different types of therapies are pretty good. I mean, these are NNTs and effect sizes, which are pretty good. And later on, I will show you that there is no significant difference between the types of treatments that there are. And that's important for the discussion about digital interventions. But I will come back to that. So, as I said, effect sizes are so very difficult to understand what it actually means. So what we recently did in a paper, which was just published in Acta Psychiatrica Scandinavica, is that we look at the exact proportion of people getting better. And that has all kinds of difficulties as well. And not all studies report that. But we used a statistical trick to extract these data from the means and standard deviations that are reported in the papers if the study didn't report response, remission, and reliable change. So, so we had 228 randomized trials, 75 were high quality, which is a very important problem. I will come back to that too later. So a lot of studies on psychotherapy have a low quality. And so what we looked at response, meaning that a reduction of 50% of the symptoms compared to the baseline. And we also looked at remission, so that people are really better. They have a Hamilton score of 7 or below after treatment. And we looked at reliable improvements and reliable deterioration. Well, this is what we found for response rates. So if you look at all the studies on psychotherapy within the psychotherapy conditions, you see that 41% response. So 41% of people with who get the psychotherapy have a reduction of 50% or more in their symptomatology compared to the baseline. That's not very much. That means that 60% do not respond. So these treatments, they work, but they don't work that well. And if you look at the control groups, you see that 17% responds to care as usual control groups and 16% to waitlist control groups. And for the other outcomes, remission, about 1 in 4 person who gets a protocolized therapy is remitted after the therapy. 1 in 4. Okay, this is just to give an idea of what treatments do. I mean, I won't go into this, but this is also what we find for pharmacotherapy. So pharmacotherapy, they have very comparable response, remission, and deterioration rates. What is important when we're talking about psychotherapy for depression, we have done most of our studies on adults, but there is also quite a lot of research on children and adolescents. And we worked with a group of John Weiss from Harvard to see whether there are differences between adults and children and adolescents. And here's what we find is that when people are adults, then the effects are pretty consistent. So it works in young adults, middle-aged adults, but also in older adults of 65 and or 60 and older. And there are now also enough studies to say something about the older old adults, people of 75 and older. And it really, the effects don't differ from each other. So the effects are, once people are adults, therapy works. Not very good, as I just showed you, but it works across all age groups. But in children, especially in children, but also in adolescents, the effects are much smaller. And that's something that's very important from a clinical perspective. We also did a study in which we looked at the response rates and remission rates, etc. And what we see is that the response and remission rates are very comparable to those in adults, but the number of people getting better in control groups is larger in children and adolescents than in adults. So it's not the response rates of therapies that is so very different. These studies do not only show that therapies have an effect on depression, which is obviously the primary outcome, but a lot of studies also look at secondary outcomes like quality of life, social functioning, hopelessness, social support, and they find pretty good effect sizes for that too. So psychotherapy for depression also has an effect on quality of life, social functioning, social support. Strangely enough, there are only very few studies examining the effects of psychotherapy for depression on suicidality. And yeah, we did this meta-analysis, I think, in 2013, and we only found 4 studies, and we really can't say whether psychotherapy has an effect on suicidality. But we're updating this now, and maybe we now have enough studies to say something about this. There's also a very small sample of studies examining the effects of psychotherapy in depressed mothers on their children. And they find also an effect of, if you treat mothers with depression, that has a positive effect on the mental health of their children. And therapy also improves the interaction between mother and child and parental functioning. We have examined many more, I'm looking at the time. Yeah, we have examined many more things. So we found no difference between treatment formats, which is crucial for digital intervention. So I will go into that in more detail later on. But we also found there's no indication that therapies have different or differential effects in students, in older adults, when people have a comorbid general medical disorder like a heart disease or cancer or diabetes or HIV. The effects are very comparable in postpartum and perinatal depression. But we do find that possibly the effects are smaller in chronic depression when people have a comorbid substance use problem, in subthreshold depression, so people do not meet diagnostic criteria for a depressive disorder, but still have some symptoms. That's not so strange that the effects are smaller then, because the room for improvement is smaller. And we do see that if you treat people with subthreshold depression, that the chance of developing a major depressive disorder at follow-up is reduced, significantly reduced. We also find that the effects on inpatients are somewhat smaller, but that has probably more to do with the type of control condition, because people in inpatient settings get a lot of treatment. I am checking whether everything is going well. Well, strangely enough, we did not find an association between the number of sessions and the outcome, and also no association between the contact time between the therapist and the patient, not related to outcome. No significant association. We only looked at that in individual trials, and this is also one from 2013 or something. We're updating it now, so we're looking into the question whether that's still true if we look at all current evidence. What we did find, by the way, in this study is that it's the number of sessions and contact time is not related to the outcome, but the frequency is. And that means that if you give 2 sessions per week, then the outcomes are better than when you give 1 session per week. And that's my colleague Marcus Huibers did a new trial on this. It was with Sanne Bruinings, one of our PhD students. And the paper was published, I think, last year in the British Journal of Psychiatry, and we confirmed this. So the frequency, if you give people 2 sessions per week, the outcomes are better than when you give 1 session per week. There is also more and more research in low and middle income countries. So traditionally, much of this research is done in the US. Since the mid-1990s, it's also done a lot in Europe. And now the number of trials in Europe and the US are very comparable in terms of numbers. But since the 2000s, we all also see a lot of trials in other countries, Latin America, but also East Asia and Africa. And we did one meta-analysis on this, and we found that psychotherapies are also effective in low and middle income countries, in non-Western countries. And we even found a small superiority of psychotherapies in low and middle income countries, but that may be an artifact. And I won't go deeper into that because otherwise you will all have fallen asleep right away. So that's what you have. Another thing that you have to remember when we talk about psychotherapies for depression is that a lot of trials are just not good. There are indications that the use of waiting list control groups actually overestimate the effects of treatments. Because we don't know exactly the reasons, but we find much larger effect sizes when waiting list control groups are used compared to care as usual control groups or pill placebo control groups. We know that risk of bias is very high, and that's you can see that as an indicator of the quality. So 80% of the randomized trials in this field have some risk of bias. That's not an exception. That's also true for in most other areas of the biomedical field, so to say. It's also true for antidepressant drugs, where also by far the majority has some risk of bias. Publication bias is also a big problem. So if you do not find significant effects, then many studies are not published. And then when you look at the pooling in meta-analysis, where you try to get all the studies together and the ones with zero effect are not included, then of course you overestimate the effects of a treatment. Again, not just a problem of psychotherapy research, but it is a big problem in the whole biomedical field. And we have looked at that in the NIH database of grants that were given on psychotherapy research for depression. And we found that about 25% of the trials were not published. And we could get the data from these trials. And then if you add that to the other trials that were published, you see that the effect size goes down pretty much. And we also have all kinds of statistical things to adjust for publication bias. So this is really a big problem of not only our field, but also in our field, so to say. And if you take all these things together, then the effect sizes, so if you make these very big meta-analysis and you take all these things into account, then you see that the effect sizes sometimes drop with more than 50% after adjustment for these problems. And if you want to know more about this, you should read the paper I wrote with my colleagues on this in Epidemiology and Psychiatric Sciences in 2019. Okay, enough said about psychotherapy in general. And I want to switch now to, internet interventions. Are they effective and how do they compare with face-to-face therapies? Because, well, we've seen this during the pandemic, of course. They have all kinds of advantages. They're cheaper, you can save traveling time. There's often no waiting lists. You can, as a patient, you can work on it whenever you want. You can avoid stigma related to mental health treatments, etc., etc. There are of course, also all kinds of dangers and disadvantages. I mean, a lot of people don't want it. They say, okay, now I want to talk with a therapist, and then I have to do that online. Why? What's wrong with talking with somebody? But other people like it a lot. They say, okay, just tell me what I do, and I can do it on my own, and I don't need a human to support me. So it's very, very different per patient. But it all starts with the question: are they effective? Are internet interventions effective? And are they as effective as face-to-face treatments? And then we first have to take a step back to psychotherapies for depression in general. And we published in the June issue of World Psychiatry a large network meta-analysis on the effects of psychotherapies for depression. And I will first show you the results before I can switch to digital interventions. So we looked at all these different types. I already showed you the effect sizes, but here you see the network again. Most studies on CBT, most studies comparing psychotherapies with care as usual or wait list, but you also see the other types of psychotherapy: behavioral activation, problem solving, third wave therapies, etc., etc. So we had in total 331 randomized trials with 34,000 people. And these trials examined all the effects of these psychotherapies, comparing them with each other, but also comparing them with care as usual, waitlist, or pill placebo. And so because you do a network meta-analysis, you can do a lot of pairwise comparisons at the same time. And then you can use not only direct evidence, but also indirect evidence. So network meta-analysis are, in a way, making optimal use of the available evidence we have. And what we found in this study is we found no significant differences between therapies, except non-directive counseling was a little less effective than other therapies. But that could very well be an artifact, because counseling is often used as a control condition in randomized trials. And you don't know whether people are really trained to deliver counseling very well, because they use it as a control condition and want to show that a real therapy like CBT or IBT or whatever is better than what is happening normally in therapies. And that's often non-directive counseling. But then you don't know whether the people delivering this control therapy are serious counselors, so to say. Are they trained in this therapy? So maybe non-directive counseling is less effective, but that could very well be an artifact. It doesn't matter if you only look at studies with low risk of bias. We had enough of them. And we also found that at 12 months follow-up, most therapies were still effective. And that means, well, all these therapies have comparable effects. And that's actually going back to the dodo bird verdict. That's something that's, if you're interested in it, people in the psychotherapy who have studied psychotherapy research probably know this. But it's a definition going back. It's a story going back to the 1970s. And it comes from Alice in Wonderland, where Alice and her friends are having a contest and they're running through each other randomly. And then at some point, the dodo says, okay, the contest is over. And then Alice asks, but if it's over, who has won? And then the dodo bird says, everybody has won, and all should have prizes. And this dodo bird verdict, as it's often called, that stands for the evidence showing that all therapies have comparable effects and that there are no significant differences between therapies. And so are all therapies equally effective? Well, overall they are. Overall, the effect sizes are very comparable. And we know, but that doesn't mean that everything works through common factors, as is often assumed. Therapies can still work very differently and get to the same results. And then the mechanisms can still be very different. And if you want to know more about that, you should read the paper I wrote about this in the annual review of clinical psychology in 2019 about the common factors. But the main important question here is, okay, if all these therapies have comparable effects, what do we need at least for a therapy to be effective? What can we take away from therapies without them losing the effectiveness? So can we minimize interventions? Can we minimize these treatments and take off things that are not really needed for therapies to be effective? And that's where, and there are all kinds of methods to do that. I mean, in low and middle income countries, it's often task sharing what is used, where trained nurses deliver simple psychological interventions. But another way to minimize interventions is to use self-help interventions. And that's where we did another meta-analysis on, which is relevant for this question, which was published in JAMA Psychiatry in 2019. And we looked at the treatment formats of CBT. So, and that could be individual CBT, group CBT, telephone-based CBT, but also guided self-help. And most studies on guided self-help are digital intervention. And the idea is that you place a psychological treatment, you explain that in a book or on a website or on a tape or whatever. You put that, you explain to patients how they can apply a psychological treatment to themselves. And you give them all the reading materials, you give them homework, and in guided self-help, usually through the internet, there is a coach helping you with it, who checks your homework, who answers questions you may have when you as a patient work through this treatment. And usually this, but it's the patient who does the work. So the patient applies the psychological treatment to herself or himself. And the therapist is a coach helping the patient to work through these materials. And of course, we have unguided interventions. There are lots of websites where you can go to and you can just do a CBT intervention for depression without any interference, without any support from a human being. They're completely unguided. And so we included all the studies which examine all these different formats of CBT, comparing different formats with each other or with a control group. And we had 155 trials with 15,000 patients. We had all the different formats of CBT and the 3 control groups, waitlist, care as usual, and pill placebo. And what we found is summarized here. We found no significant difference between treatment formats. And I really have to look at the time. I talk too much, so I will go a bit quicker. So we found no significant difference between treatment formats and outcome, as long as there's human support. So you can apply CBT in groups, by telephone, individually, or by guided self-help, no significant difference in effects. If you use unguided self-help, the effects are much smaller. And I will show you later on a little more about the unguided and the guided interventions. So what we did find, and you should keep that in mind, when people do online interventions, the risk of dropping out is larger. So you should keep that in mind when you treat people online. Does it have to be CBT? No, it doesn't have to be based on CBT. This is a trial we did with our Swedish colleagues on a psychodynamic guided self-help internet-based intervention for depression. And we found that the effects are very comparable. And the question is, of course, who delivers the interventions? Do that have to be fully trained psychotherapists or clinical psychologists who deliver that? Well, we work with master level clinical psychology students, and they are trained according to the IAPT model from the UK, where they work with step care. And the first step is low intensity CBT. And the people delivering this low intensity CBT, they're called psychological well-being practitioners. And that's what we use for the coaches or the therapists delivering internet-based guided self-help. And the time that they spend on treating people is much shorter. But of course, I will skip this. Of course, it's not just only positive effects, and I will show that later on to you. But I mean, the evidence is pretty clear that if you look at efficacy studies, internet-based interventions have comparable effects as face-to-face interventions. It really doesn't matter how you apply the interventions, whether that's individual groups, but also digitally. just works. However, this is mostly from efficacy studies. So if we want to examine how can we use this knowledge, then we really have to look at the different settings where we can apply it and examine if this application in this setting for this specific target group is effective. And you can think of all kinds of things where you can use it, like prevention, that you offer it to people with subthreshold depression and try to prevent the onset of major depression. I will show an example of that. You can organize digital clinics, which may not even have a building because everything goes through the internet. And we have already all kinds of these digital clinics, so to say. But you can also think of primary care, where a doctor not just gives antidepressants, but instead first tries digital interventions or offers combined treatments of antidepressants and digital interventions. You can think of specialized mental health care. You can think of all kinds of applications in general medical care for people with general medical disorders. You can think of schools and colleges where you develop specific e-health interventions for these target groups. You can think of applications in the workplace. Some people say that you may use this in low and middle income countries where there is no infrastructure for mental health care at all, where you start building mental health care by offering first unguided interventions, which work, but not so much. And if you get a little more money, so to say, for mental health care, you start with digital interventions, which are guided. And this is something we have tested, for example, in Lebanon, with very positive results, where there's no infrastructure, but when you can use this as that you do at least something for people with mental health problems. But you have to examine that, and that's what it's not true that everything works in each of these settings. You have to examine you have to do specific trials to see where and for whom these interventions work. And I will give 3 examples of projects in which I was involved to show how does this research look like. And it's not just us in Holland doing this kind of research. There are all kinds of groups in Sweden, Australia, and more also in the United States and the United Kingdom and Germany, examining where and how this knowledge that these things work can be applied. Okay, quickly, a few examples. The first is indeed about preventing the onset of major depressive disorder and subthreshold depression. We were very fortunate that this paper was published in JAMA. It was actually led by Claudia Buntrock and David Ebert, and I worked at their institute at that time, and I was involved in this trial too. So what we did is we recruited people with subthreshold depression. So we did a clinical interview, and those with an existing major depressive disorder were excluded. And only those with symptoms but no disorder were randomized to a preventive digital intervention or care as usual. And then after 12 months, we looked again how many people developed major depressive disorder. And we found indeed that people in the intervention group had a much smaller risk of developing a major depression during 1-year follow-up than people in the control group. The second project is not about depression, but about anxiety. It was led by my colleague Tara Donker, and it's a virtual reality-based app. And the nice thing, it was published in JAMA Psychiatry 2 years ago. And so what Tara did is she developed a VR application for acrophobia, fear of heights. And the nice thing is that you don't need an expensive VR glasses, but you can use one of these card boxes. It's just paper, and you slide your phone into it, and then you have VR glasses. So it hardly costs anything if you have a mobile phone. And so the special thing about this was also that it was unguided. So this is the app is about a theater. So there's an elevator in the app, and you can use it yourself. You can handle it yourself by going up and down, and so you can get used to when you're a little off the ground, you're afraid when you have acrophobia. But it's just exposure where you get used to the fear and then go higher a little and then higher again. So it's just exposure through an app. Well, here's another screenshot where the person is standing on the top of the theater. And what we randomized 193 people to waitlist or to xerophobia, and we found very strong effect size of 1.14 for phobic symptoms. And dropout was very small, was relatively low, and a lot of people reached clinical significant change. So I think this was a very nice project. So, and the third project I want to talk about is a bit more complicated. It's about individual patient data meta-analysis to examine moderators and predictors. This work is led by my colleague Irinio Kariotaki, with whom I've been working on meta-analysis, and she's been working in my group for several years now, and she has specialized in these individual patient data meta-analysis. So if you do a meta-analysis, you can also ask the authors of the you can ask the authors of the trial to give the data to you, and then you pool all these data together in one big data set, and then you have enough statistical power to examine predictors of outcome, because individual randomized trials never have sufficient statistical power to examine who benefits from this intervention and who doesn't, because randomized trials are designed to see if something works and not for whom. But if you put the data from all these trials together, then you do have enough statistical power to see who benefits from it. And she's done several of these meta-analysis. Because of time, I will go to the last one. So this one was published in JAMA Psychiatry, I think in 2017, where she did find that unguided, self-guided, internet-based CBT is effective, although the effects are small. She did one for guided internet-based interventions, where she also found that they are effective. But the most recent one was published this year in JAMA Psychiatry. And what we did there is not a normal IPD meta-analysis, but an individual patient data network meta-analysis. So we have trials of guided CBT versus control groups. We have unguided ICBT versus control groups, and we have trials comparing guided and unguided ICBT with control groups. And then we have all the primary data of these trials. So what you can do then is you can make a profile of an individual participant and see what happens if that person gets unguided or guided internet-based CBT. And then you can get a very personal view on what would happen with this individual. So it's very much personalized treatments. In general, what we found is that people, when depression is mild, so not very severe, then we do not find that guided and unguided interventions differ significantly from each other. They're both effective compared to waitlist and care as usual, but they're not, they don't differentiate from each other. But in the more severe depressed cases, people do need guided internet interventions. But I mean, it's already a big thing that if you can give people with lower severity depression unguided intervention, that saves a lot of time again from therapists, because there needs to be no support. So this is you can go to this website and fill in for your patient the baseline severity in terms of the PHQ. You can fill in the age and a few other things, and then you get a very individual outcome for this patient, what this patient would do when she or he would get unguided or guided interventions. Okay, I will skip this. IPD meta-analysis also allow to examine clinical deterioration, which is very rare, but because you have these large sample sizes, you can examine that too. If you want to know more, just read the papers we wrote about that. But of course, as I said, I showed you the examples of the trials that worked, and they end up in high impact journals, everybody happy, and it all looks, wow, this is so new and innovative. No, it's not. I mean, we also did a lot of randomized trials that did not work. We did, for example, 2 large randomized trials in people on waiting lists for receiving specialized mental health care, one in depression and one in anxiety. And we offered people on the wait list to get a digital intervention. And we thought that a lot of people, if they would get this digital intervention, that they would not need face-to-face treatment anymore, or at least that when they would get face-to-face treatments, that they would need less sessions of treatment. Both was not true. We did find small effects, some, but not very convincing. And it was not cheaper, and did not reduce the sessions after that. So these failed, and these were 2 very big trials. We did 1 trial on internet-based problem solving for a Turkish minority in the Netherlands. We did not find that it was significant. We did 1 trial on internet-based prevention of depression in employees in big companies in the Netherlands. It was not significant. So it's not everything works if you do digital research on digital interventions. So very briefly about the future. Well, you have to be very careful when making predictions, especially about the future. I don't know who said that, but I thought it was pretty funny. But this is also one thing, making clear that you should be very careful with making predictions about things in 50 years. This is from a newspaper in the 1950s on how they thought a home computer would look like in 50 years. Yeah, and well, I think one of the mobile phones we have now, or we had 10 years ago, had much more capacity than the thing, sorry about that, than the thing you see here. And so I think this is pretty funny, showing that you shouldn't make predictions of the future, especially about technical things. So what is important to keep in mind when you think of digital interventions is that they started about 20 years ago when the internet came up. I think I got my first grant on a trial on internet interventions in 1998. That's more than 20 years ago. And we had the first trials published in the early 2000s. But what these trials did is that they simply copied face-to-face treatments, made a self-help intervention of that, and then applied it through the internet. Some even had, PDF files which were online and you could read them online. So very simple. But in the last years, we see this whole mobile revolution coming up with thousands of apps for mental health problems in the app stores. And more people use their mobile phones in a completely different way than they use their computer. I mean, the traditional internet interventions are developed for people who sit behind their desk, read all these materials, and fill in all these questionnaires and do these homework assignments while they're on a big computer. But people use computers less and less. They use mobile phones, they use iPads, tablets. And that's going to make a big difference, because the mobile phone has all these sensors. You have it with you all the time. And you can collect all these data on these cell phones about what's happening now in real life. You don't have to fill in a questionnaire how you felt the past 2 weeks. You can fill in now how you feel on a rating scale between 0 and 5. And so it's moving away from reflecting on how you've been feeling to measuring now how you feel, and that combining that with all the data that are collected by smartphones. And that's, many people think that will revolutionize digital mental health. And I think that could be true. I haven't seen it yet. There are an increasing number of trials on apps for mental health, and they do find effects, although they're pretty small. And I haven't seen yet effect sizes which are coming close to the guided self-help, which I showed you earlier. But it's also, it is a promise that the field has, that there are the big data that you collect, machine learning techniques that you can use to apply treatments in individual cases. So that's a big promise that is coming, that is already there, but that has to be examined for some time to see whether that actually can improve outcomes. So I come to my conclusions. I think there's no doubt that internet-based treatments for common mental disorders are effective. The challenge is to implement them in healthcare, and we don't know where and how we can apply this. And it's in a way we are caught up by all these fast developments with the mobile revolution, changing mental health quickly. But I don't think there should be any doubt that the internet and digital interventions will have a considerable and lasting impact on mental health care. And I thank you for your attention. If you have questions, you can ask them now. I think we have time for questions, but you can also always send an email to me, or if you want to know more about me or my work, look at my website. Thank you very much for your attention.
Thank you so much, Dr. Cuijpers. This was amazing to hear this first-hand information from a leading expert. So it is amazing, and we do have some questions from our audience who have been watching this conference from all over the country, Mexico. So, Sandra Cerezo asks, well, we have partly answered this question, but why does a large number of people do not respond to treatment? Is it related to severity, maybe to a neurochemical imbalance or neurochemical maturity? What are your best guesses about this situation?
Yeah, I mean that's a very obviously a very important question, but also one which is very difficult to answer. We simply don't know. I mean, if we even don't know what depression is. we know that it exists because we see patients having depression and we see that they suffer. But we define depression as something when people meet some criteria. And these criteria are based on what a working group of the American Psychiatric Association has said that that's depression. And of course, there is some kind of evidence supporting that. But if you read, we don't have a test for depression. We don't know whether it's a psychological disorder or a biological disorder or a combination of the two. We just don't know. And so we know so very little about depression, about what it is, where it comes from, why this person gets it, the other one doesn't, how that affects the brain, or whether it's coming from the brain, or whether it's psychological. We really don't know. And that means that, I mean, we have the design of randomized trials to examine if a therapy works. And that design is very strong. That's scientifically the best design we have. It's an experiment. And so we can show if a treatment works, but we cannot show how it works. And we also cannot see why somebody responds to it and another person don't. We simply cannot use this strong experimental design of the randomized trial to examine that. So yeah, it's a bit, I'm afraid that I don't have a better answer to this. We just don't know. I wish we knew.
Yeah, that's true. And with regard to evidence and what constitutes a good or a better experimental design, Javier Rios also asks, how can we improve the quality and quantity of psychotherapy evidence? And let me frame it in, the Mexico and other low and middle income countries where conducting an RCT, a randomized control trial, may be too expensive. So what can we from these countries do to improve what we know about psychotherapy and how it works and why it works?
Well, I mean, there is a lot of evidence for some interventions, and I mean, when you think of low and middle income countries, you don't only need digital interventions. You can also think of task sharing interventions where you implement simple psychological treatments in primary care, for example. And the WHO does a lot of research on those interventions. And we help the WHO to do this kind of research, but also to implement it later on. And but I do think that if you that digital interventions are, as I said in my presentation, they could be some kind of basic, yes, that you do at least something for people with mental health problems, and you can offer them digitally, and that allows people with who have a smartphone or a computer or internet access to use that. The problem is, of course, that a lot of people don't have that, but you can still make I don't know, booklets, brochures. I mean, the idea of guided self-help is nowadays applied a lot through the internet, but there's no reason why that would be different if you make booklets and give people a booklet and say, I will call you now 4 times every week in the coming 4 weeks to help you work through this booklet. That works just as well. So it's not the technology that makes internet interventions work. It's the guided self-help intervention that makes it works, and that's not limited to a digital environment.
While Dr. De La Rosa's labs has been working on guided self-help interventions for some years, there's also an interesting starting to work with unguided self-help interventions. While they are not as effective as unguided ones, we believe this could be like a first stage in a massive intervention that could help people who don't may not have as severe disorders as people who actually require or need a guide. So you mentioned this amazing meta-analysis, which, to be honest, I was not aware of. This IPD network meta-analysis just published, and you mentioned that one possible moderator is the severity of the disease, how severe disease is or disorder is. Which other moderators have you found in your research that could guide us as to how or for whom unguided interventions may work better?
Yeah, the first IPD meta-analysis on unguided interventions is from 2017, and we did not find any predictors of outcome. So that's one of the problems of IPD meta-analysis, that you depend on the predictors that are common in all trials. And trials are often still having all kinds of predictors that are not used in other trials. And then an IPD meta-analysis doesn't add very much. We did another IPD meta-analysis in 2018, which I showed in Clinical Psychology Review, but that was on guided interventions. And there we found that guided interventions work better in more severe depression. So you would think that it's less effective because, a lot of people think that if severity is higher, then these things don't work because it's people need more intensive treatment. But that's not what the data say. Another thing is that older people benefit more from interventions. Also, not what you would expect. You would expect that especially young people benefit from it because they are used to working with digital tools. But that's not what we found. So we found that it's older people who benefit more. And in this trial, or in this meta-analysis, we also found that people from ethnic minorities benefit less from the interventions. Yeah. But as I said, the latest IPD network meta-analysis goes a step further. And all the predictors are there, but you can fill in all the individual predictors and then see what happens with an individual.
Okay, thank you, Dr. Cuijpers. One last question that it comes from myself. VR, virtual reality, has been studied, especially for phobias, and you mentioned the zero phobia study. But are you aware of any study, be it already concluded or being conducted at the moment, about VR for depression or suicidality or self-injury? Are you aware of something like that?
I think VR applications are mostly examined for anxiety and for pain. And there's a lot of research on VR for pain and for anxiety. I don't know many studies on depression because it's not clear what environment you should make for depression. I mean, for phobias, it's clear. You just go, you go into a hall where all these people are sitting, and that's where you're afraid of when you have social anxiety. Or you go into a room where you in an elevator with acrophobia. But for depression, it's not so easy to identify the setting. Another big problem of VR is that most studies find that it's effective, but it's not more effective than face-to-face therapies. So then the advantage of VR applications is pretty limited because unless you can make an unguided version that you can apply yourself, otherwise you will have to go to a lab where you get a VR glass, but then you can also just do normal exposure, so to say. So the benefit is, theoretically, it's highly interesting, of course, because you have these fears. Well, they're not real, and that's highly interesting. but clinically it's not adding that much.
Mm-hmm. Well, there are many people saying thank you, Dr. Cuijpers, for this lecture today. As said, many people are listening and watching this presentation from all over Mexico. So it is a space or a place where we have been able to share part of your knowledge and research with people from all over the country. Well, I think that would be everything for today. I really want to thank you. And on behalf of Dr. De La Rosa, thank you for everybody who has been watching this presentation. I will switch to Spanish to direct myself to the audience. Muchas gracias a todos los asistentes y muchas gracias al Dr. Ben Cuijpers por su presentación, que nos ha dado muchísima información muy importante, muy relevante y de primera mano. Como dijimos al inicio, eres un experto internacional en estos temas y es realmente un honor tenerlo aquí. It is an honor, Dr. Cuijpers, to have you here. Thank you. And thank you, everybody.
You're welcome.
Y nuestra siguiente presentación, que sería la última del año, estaremos por redes sociales pues, promocionándola y estén atentos entonces a la página del LabSit. Muchas gracias. Thank you.
Bye.